Thank you, Satish sir, for those words of introduction. And at the outset, let me thank Astellas for this opportunity, as well as Extracorporeal Group and GKM sir for this wonderful opportunity. And today, as Sir has already mentioned, we are going to discuss on an important topic, that is on ABO incompatible renal transplantation. And as you all know, transplantation offers the best survival as well as quality of life in patients with end-stage renal disease. And many patients may not have a suitable ABO compatible donor, and our disease donor program is also not happening very often. And so this is one of the ways to expand the donor pool. Though it is fraught with major challenges like increased risk of rejections, infections, bleeding complications. With the advent of better preconditioning protocols as well as desensitization methods and post-transplant monitoring, we have been able to achieve good outcomes. So a critical barrier to allograft survival and patient access to transplantation are these antibodies which are directed against the transplants, specifically the isoagglutinins, which are antibodies, natural antibodies, which are directed against the non-self ABO antigens. So antibody incompatible transplantation can be stated as an organ transplant into an ABO incompatible recipient. And these are important because these antigens are expressed on the glomerular endothelial cell surface, but not the Rh antibodies. And this antigen-antibody interactions can activate the complement and can lead to rejection. So over to the first poll of the day. Sadiq sir?
Yeah. So I just want to
Can you go ahead to the poll?
Have some general views about this ABO transplant. How many of us are actually doing it? So can you launch the poll one? Sijo? Rahul?
Yes, sir.
Yeah.
Poll is
So you're the first poll, so you can all answer. Are they doing ABO transplant at your center or not? That's the only question. I think it's not something which requires knowledge. So can we close the poll now? If enough people have answered. Yeah. Oh, it's quite a big number. Almost 50% are doing it. So it's not something which is uncommon practice. So we'll continue. Having had knowledge in mind, I think we can continue with this presentation.
Okay. Trying to move on to the next slide.
Yeah. It's not moving.
Can you stop the poll?
Yeah, you can close it.
It's not moving.
Rahul, you can close the poll. And
yeah. There's that blue button, no? Close.
So let us go look into the significance of ABO incompatible organ transplant.
This
one is that increase the donor pool. ABO incompatible transplants allow. So ABO incompatible transplantation can increase the donor pool, allowing patients to receive kidneys from donors with different blood types, which may help to expand the donor pool. And this also helps to decrease the waiting time for these patients. And also with the advent of better desensitization protocols and immunosuppressive regimens, there have been increased outcomes with graft and survival outcomes with ABO incompatible transplant. And this offers a hope for these patients who may have to otherwise remain on dialysis with its attendant increased morbidity as well as mortality. So regarding ABO incompatibility, there is a unique concept of accommodation. So this is a chronology of rejection and accommodation, which happens in ABO incompatible transplant. So in ABO incompatible transplant or other transplants, if ischemia reperfusion injury as well as antibodies which are directed against the ABO antibodies as well as and HLA antibodies can result in complement activation. And if this complement activation is robust and severe, this can result in hyperacute rejection. This may happen over minutes to hours. And lower level antibodies can again may result in early acute rejection weeks after transplant, and months to years you may have acute rejection. In the case of ABO incompatibility, there is heightened risk of hyperacute and early acute rejections. Usually, this is evident till for the first 2 to 4 weeks post transplant. Thereafter, the risk of rejection is comparable to ABO compatible transplant. So, why this occurs is due to a phenomenon called accommodation. So, accommodation is a process whereby, though the antibodies are present in the body and may lead to antibody mediated rejection, the event is not happening. So there is a resistance to the injury, tissue injury or transplant organ injury, despite the presence of antibodies and leading to no rejection episode. So the exact mechanism for this accommodation is not very well known, but this has been speculated because of the intrinsic threshold to the complement as well as or antibody mediated injury to the transplant. And there is increased induced resistance, and there may be some change in the antigen as well as the interaction of the antigen with the antibody. And there is increased anti-apoptotic gene expression, which may give resistance to humoral antibody mediated rejection. And simultaneously, some repair mechanisms may also be happening. And there is blood group chimerism. So there are various postulates for this accommodation. So this accommodation is can be defined as the absence of immune response to the allograft despite the presence of antibodies, which are capable of inducing antibody mediated rejection. So in ABO incompatible transplantation, the major barrier is the anti-A or anti-B or ABO antibodies or isoagglutinins, which can cause antigen antibody mediated rejection. And the critical thing is to reduce these titers prior to the transplantation. So the anti-A or anti-B titers should be reduced. And for this, we have got various removal techniques, one of which is plasma exchange. So with the help of these antibody removal techniques and B cell depletion therapies, the outcomes achieved are comparable to that of compatible kidney transplantation. So this is a study which has compared the long-term and patient as well as graft survival outcomes in living kidney transplantation by desensitization protocols, where ABO incompatible was compared to ABO compatible. This is one of the earliest studies by Tanabe et al. So these were the Japanese people who first pioneered the extensive use of ABO incompatible transplant. And this study was in 1998, where they looked into 67 patients with ABO incompatible kidney transplantation who were rigorously desensitized with plasmapheresis as well as immunosuppressive therapies, were compared to ABO compatible transplant. And they found that the graft patient survival at 1 year was 93%, and at 8 years was around 8%. And the graft survival was around 80%, close to 80% at 1, 2, 3, and 4 years. But thereafter, the graft survival was around 73%, which was comparable with the ABO compatible transplants. How they found that initially there was higher early graft loss, but there was equivalent graft survival after 4 years. So this was the first study to support ABO incompatible kidney transplant as an acceptable treatment to expand the donor pool. Now, recent studies have found even comparable first year as well as 5-year graft survival rates. So let us look into the evidence-based strategies to overcome the ABO incompatibility. So to overcome this ABO incompatibility, we need to have a preconditioning regimen, which will include a B cell depletion therapy like rituximab, then the antibody removal therapy plasmapheresis, and in some situations, IV immunoglobulin is also used. So rituximab is anti-CD20, which targets B cell depletion, which will reduce the anti-ABO protection. And then you have got plasmapheresis, which rapidly lowers the circulating anti-ABO titers before the transplant. And IVS is supposed to neutralize the antibody rebound as well as residual antibodies, as well as modulate the immune reconstitution. So let us look into each of these evidence-based strategies one by one. First is about the role of rituximab. Rituximab is anti-B cell depleting therapy, which helps to reduce the antibody production. And there have been several studies on rituximab in ABO incompatible transplantation, one of which of notice by Fushnov et al. This was a study in 2011. So they began using rituximab from 2002 onwards, and they looked into the long-term effect of rituximab as a part of preoperative regimen for ABO incompatible transplantation. The group was divided into three groups, where group A was ABO compatible, and then there was a group ABO incompatible without rituximab, and third group with ABO incompatible with rituximab induction. So they found that the outcome was better with a preoperative regimen containing rituximab induction in terms of better graft and patient survival outcome, which is even better than ABO compatible kidney transplant. So they supported the use of rituximab prior to ABO incompatible transplant. So this is a recent study by the Australian group. This was a single center study, which has compared between the ABO compatible versus ABO incompatible with rituximab and without rituximab. So they had 66 consecutive patients who were on who were not on B cell depleting therapy, because at that time there were a few centers which looked into the beneficial aspects of B cell, avoiding rituximab because of the supposed high increased risk of infections and all. So this study, they had 18 patients who had rituximab as an induction, as a preconditioning regimen, versus 66 patients who were not on rituximab, which was compared with ABO compatible live kidney transplantation. So what they found was that in rituximab-free ABO incompatible transplant, there was high increased odds ratio of acute rejection when compared to ABO incompatible on rituximab, as well as ABO compatible transplantation. And again, 6 cases of refractory AMR was requiring splenectomy was noted in the rituximab free ABO incompatible, and there was 2 early cases of graft loss, which was not noted in the rituximab in the induction group. And this was also, there was also not a decrease in serious infections in patients who were not on rituximab. So, and the overall graft and patient survival was not different between the three groups. So this study they highlighted the continued inclusion of rituximab in ABO incompatible desensitization protocols. So there have been various regarding the dose of rituximab. There have been a lot of controversies. So going to the next poll.
Yeah, thank you, Jithin, for that. So just this poll is just to see what dose of rituximab you're using in adult, because we know that a lot of doses are available, and some are using high doses, some are using low doses. So the trend is to use lower doses nowadays. So can you run this poll, please? 100 milligram, 200 milligram, 500 milligram. So poll is starting now. So you can submit your poll results. Okay, you can close the poll now. And share the results. Yeah, I think most people have chosen 200 milligram doses. I think that's a fairly reasonable way of doing it, because 500 milligram is too much. And probably, I think the answer here was 300 milligram in this poll. It was actually meant to be 500 milligram. But anyway, 200 milligram is the answer that we're looking for. Dr. Rajesh, could you just tell us what doses do you use and why you chose your particular dose? Dr. Rajesh? Rajesh is there? Busy.
Okay. Can you hear me? Hello?
Hello? Yes, yes, yes. You can hear,
Yeah. So initially, actually, most of the centers were using 500 milligram, 500 mg of Rotux, but over a period of time, we understood that the lower doses are actually equally efficient, and maybe significant immunosuppression and B cell depletion is adequately done with it, even 200 milligram of Rotux. So we use actually 200 milligram Rotux. Probably I'd like to tell that in case the patient goes in for further immunomodulation and other things, it is better to keep the Rotux dose lowest as possible, because this patient is likely to go in for further such as the plasmapheresis and thymoglobulin or bacillus induction. So, expecting more immunosuppression in due course, it is better to keep the Rutux dose at the lowest possible. And we have seen that 200 milligram works very well. And the Indian Working Group guideline also has recommended 200 milligram Rutux to start. Thank you. Yeah.
Yeah, I think that's correct because I was also started using 500. Then we had the Medanta study, which showed that 200 milligram was effective in a HEA, large group of patients. After that, we also switched to 200 milligram. So I think continue with your presentation, Dr. Jithin.
So we'll going to the next slide. So I think everybody agrees with the lower dose of rituximab, that is 200 milligram. Can you close the poll so that I can move on to the next slide?
Rahul?
Yeah.
Somehow the slide is
You can-
getting stuck.
Yeah, sir, please close on the web, close, sir. Please close on the poll.
Yeah, sorry. So, regarding the dosage of rituximab, this study actually looked into low dose rituximab in ABO incompatible versus ABO compatible kidney transplantation, which looked into 5-year patient and graft survival. And this was a study by Hatakeyama et al. In 2014, where they looked into 42 patients who underwent live kidney transplantation, were divided into two groups, ABO compatible and ABO incompatible, using low dose, that is 100 milligram per meter square, without splenectomy. And the basic immunosuppression was comparable between the two groups, and the infections as well as the episode rejection and graft survival were compared. And as you can see, the graft survival was almost 100% in the the low-dose rituximab group, ABO incompatible, and the patient recipient survival was also close to 100%, and the 5-year patient survival was 100% in both groups, and the incidence of rejections were also not very different. This supported the use of low-dose rituximab in ABO incompatible transplantation. Now, moving to the antibody removal therapies, which is very important prior to ABO incompatible transplantation, which can be achieved through various processes. One is the plasma exchange. Then you got the double filtration plasmapheresis as well as immunoabsorptive therapies, which may help to bring down the antibody levels. So the importance of plasma exchange has been highlighted by various studies. One is a study by Yu et al. And then there's another study by Hanoka et al. So the Yu et al. Study, they looked into the advantage of plasmapheresis for removing these antibodies prior to ABO incompatible transplantation. And the patients received plasma exchange or IG administration. And they found that on day 14, the EGFR measurement, and there was immediate recovery of renal functions in 10 patients. And again, there's a study by Hanoka et al. Where they looked into the plasma exchange as selective plasma exchange as apheresis before ABO incompatible transplantation. So in selective plasma exchange, there is they have got a filter with a smaller pores so that the immunoglobulins are effectively removed, and when the albumin is replaced back to the patient. So they divided this patient into two groups, one which is replaced with albumin alone, and other group where they replaced with fresh frozen plasma, which is a group F, and compared the clinical effectiveness. So they found that selective plasma exchange using fresh frozen plasma may be beneficial treatment modality. One is it reduces the bleeding complications, and also the reduced number of the exchanges were required, and the antibody titers came down significantly. So they found that a selective plasma using FFP may be a beneficial treatment modality. So let us go into the next poll.
Yeah, okay. So this poll is actually, we put it up to see what type of antibody removal techniques that people are using during the procedure. So we have Plex, we have double filtration plasmapheresis, and we have immunoabsorption columns. So each have their own uses, but I would like to generalize. Some people may be using both. So you can just say which one you're using most commonly. So can you launch the poll, please? Yeah, okay, you can close the poll now. Share the results. Yeah. So large majority is using Plex. Only few people are using DFPP and columns. I think so. I think you can just find out from Dr. Rajesh what techniques are you using, and do you use all of these techniques or only some of them? And if there
Yeah,
are any
actually,
particular reasons.
yes, actually, we have used all the three, and there are pros and cons for each. But by and large, if you consider the cost and the feasibility and the overall outcomes, actually, we can resort to plasma Plex itself. Because DFPP, the advantage is that the removal of globulins is better. 70 to 80% of the immunoglobulins is removed, but it is expensive. And immunosuppression column is even more expensive. So practically what we can look at it, if you feel that patient may need more than 4 to 5 plasma pheresis sessions, probably there is a case to consider glycosorbate immunosuppression. Immunosuppression column can be actually reused, even though strictly speaking it should not be. So the price may even out in that aspect. Otherwise, we are now resorting to plasmapheresis only, which gives fairly good results.
Yeah.
If you look at the study, the multi-center study which has been published in Transplant, actually, yeah, your center was also part of it. The patients who have undergone immunosuppression column, the outcome was not that great.
Not that great, correct.
Not that great, yeah.
In our
That
study.
is an observation.
I think that Jithin is going to present that also in this course of this presentation.
So practically, feasibility wise, expense wise, Plex is probably the way to go. So far as we are concerned.
Yeah, I agree with that. So I'm also using Plex. When the antibody levels are higher, I use DFPP in order to reduce the number of sessions. Probably it becomes more cost effective when the antibody levels are higher. So I have not used columns so far, but there are people who are only exclusively using columns. So I don't know. So how far maybe the people who are using columns may have better experience and may have better outcome when they are using columns.
But there are no head-to-head comparison between the each.
No, absolutely no. So it all depends on what you're, and I don't think there is much difference. But if you have a small titer, then definitely I don't think you should use any of the costly techniques, and you should go ahead with Plex. I think Anjana has asked a question. Which titers do you use DFPP? I think more than 1 in 64. Say up to 1 in 64, I use Plex. If it's 1 in 128 or more, I try to use DFPP because. And the other problem is sometimes in Plex, I think Rajesh should also notice that sometimes when you do Plex, the titers don't come down. They just remain stuck. And then you can go for a slightly, even with 1 in 64, sometimes it remains 1 in 64.
The Indian Working Group guidelines, which has come in IJT, they also suggest if you feel that you are going to need more than 4 sessions of plasmapheresis with very high titers, then probably it is better to resort to either DFPP or columns, immunosuppression columns.
Yeah, I think that's absolutely fine. Is there anyone else here who has some experience in this? I am not seeing. Dr. Sneha is here. So in that case, we'll go ahead with the next part of the presentation. Yeah.
So most of us prefer plasma exchange because of its cost effectiveness and ability to bring down the antibody titers significantly in majority of cases, unless the titers are quite elevated, or if you are requiring more than 3 to 4 sessions, or if it is not coming down with plasmapheresis. Then you got this double filtration plasmapheresis, which is more selective, that in that it can remove the immunoglobulin fraction more selectively, and as a result of which you can minimize the volume of substitution fluid that is required. So in this procedure, around 0.5 to 1 liter of 8% albumin solution was used as a replacement fluid, and which is equivalent to around 2.5 to 5 liter of fresh frozen plasma, which you may use in a regular plasma exchange. And so this is the flowchart of the double filtration plasmapheresis, the cartoon representing that. So here you have got a plasma separator, which will separate the plasma, and then you have got an additional filter called a plasma fractionator, which will separate the larger molecules like the gamma globulin fraction, while the albumin and the rest of the things are returned back to the patient. So there's a targeted filtration which is happening here, and it is more efficient. And one double filtration session removes as much globulin as is found in 5 liters of plasma. And you need only 1 liter of substitution fluid when compared to the significant amount which is required in plasma exchange. So again, the risk of bleeding as well as the replacement requirement is less with double filtration plasmapheresis. And this is the effect of double filtration plasmapheresis on immunoglobulins. So they found that IgM removal is approximately 70% with a single treatment, and IgG removal is up to 60% by single double filtration plasmapheresis treatment. So regarding another plasma fractionator, which may raise the cost of the treatment, but in situations where the titers are not coming down, this may be an effective method. And regarding the immunoabsorption, as already stated, you have got glycoside columns, which can be anti-A or anti-B or as ABO columns, which is more expensive. And if the titers are quite high or requiring more sessions, you might resort to immunoabsorption columns. Now, going ahead with the desensitization protocols with ABO incompatible transplantation, there have been various modifications. There is no uniform protocol or recommended protocol. So different centers use their own protocols with some modifications. So the basic protocol involves rituximab induction along with sessions of plasmapheresis, and then you might have induction therapy. So the ABO incumbent transplant uses pre-transplant antibody removal with plasmapheresis or immunosuppression along with rituximab and in immunoglobulin plus potent maintenance immunosuppressions, which are tacrolimus, mycophenolate, and steroids to prevent the rejections. So induction agent may be used, which can be most often basiliximab. So what induction, the pole 4, going to the pole 4, Sajesh sir?
Yeah. So again, the practices in induction, because induction is a key component of the ABO incompatible transplant. So which are you using, basiliximab, or are you using anti-thymocyte globulin or grapholone, and no induction? These are 3 possibilities. So please, yes, the poll is launched, so you can take part in the poll. Okay, you can stop the poll, launch the results. So I think most people are using ATG grapholone. I think that's a point to discuss, because we are using so much of immunosuppression. This you are doing rituximab, you are giving plasmapheresis. So which is the way to go? I will ask Dr. Rajesh to explain. Dr. Rajesh?
Yeah, Sadish, actually, I thought I will discuss a bit on this. See, once we give Retux, we are actually wiping off the B cells. Once we give thymoglobulin, the T cell is also washed off. So actually, you are giving a complete, total immune paralysis. It's completely, we are actually blocking the immune system. So actually, we have seen that our limited experience has shown that if you give Retux followed by thymoglobulin, the incidence of infections are much higher, and we have lost few patients because of infections, especially in the first 1 year post transplant. Most of them have received Retux and thymoglobulin as induction. So the currently we are switching towards, actually we have done 1 or 2 switching towards basiliximab induction, and based on the induction regimen after you give Retux has to be based on the HLA risk, the HLA antibody related risk. That is very important. So we forget that the patient is going for an ABOI based on the HLA immunological risk stratification. You can consider induction. I understand the Calicut group is actually not giving induction. They go ahead without induction. So the general guideline is that if you feel that the anti-HLA antibodies are high and the titers are probably demanding an induction, probably you are justified in going with thymoglobulin. Otherwise, no induction or basiliximab should be fine. If you look at the study, which the multi-center study from India, the QT group is published in Transplant. Yeah, you are also part of it, Dr. Satish.
Yeah.
Basically, the issue was basically infection only. The infection was the Achilles heel so far as ABOI is concerned. and most of the deaths
Yes,
were due to infection. Yeah. So I would probably
think,
look at it this way:
yeah.
you give a 200 milligram of Rutux and do a appropriate plasmapheresis to get the titers to an extent. Titers we'll be probably discussing further now. And basilisumab induction is probably, if you want to induce, prefer basilisumab, and the thymoglobin only in selected cases. Yeah.
I think we had discussion with Tanabe also during, he's one of the world authority on ABO incompatible transplant in Japan. And they also, because of infection, they switched to besiliximab, and now they claim that their infection is the same, whether they're doing incompatible or compatible. So
The
that's a
Japanese
point to be.
group is actually totally different race.
Yeah. They're not even doing flex. Even
they even don't do they even don't give antibiotic prophylaxis following transplant.
oh, that's great.
They don't
And
believe in
nowadays they're not
antibiotics.
doing plex for even 1 in 64 titer.
Yeah.
So I think
That
in our
is
place that may be a disaster.
that is a little too much. That is a little too much. You become more confident as you do more. That's it.
That's what. But I have not become confident enough to do without plex. Yeah. If there are any viewpoints on this, please welcome. Anybody else want to? You can just put on your video and talk. Yeah. So in that case, we'll continue the presentation. Dr. Jithin.
So the preferred induction agent, according to everybody, is basiliximab because of reduced risk of infection, and in certain situations with HLA incompatible situations, you might even think of ATG. So these are the various desensitization protocols for ABO incompatible kidney transplantation, modified across various regions. So there are some differences in each of these protocols. So first, the Japanese protocol, where they use rituximab as an induction agent, usually a low dose 200 milligram, at least 2 weeks, that is 14 days prior to the transplant. Usually rituximab is given in majority of centers 1 week prior to the plasmapheresis. So this in the Tokyo, they have got the double filtration plasmapheresis followed by induction with anti-IL-2R. And in the German protocol, they give rituximab 1 month prior to the transplant, and there is immunoadsorption along with IVIG, and they also give post-transplant immunoadsorption, which is not practiced in many centers. And again, the Korean protocol has got a rituximab 1 week prior to the plasmapheresis, and they give plasmapheresis along with IVIG and induction with basiliximab. And then the John Hopkins USA protocol, where again they use a combination of plasmapheresis with IVIG, and they also give post-transplant plasmapheresis with the induction with basiliximab, and rituximab is given close to the transplant. So there are varying protocols. So coming to an Indian protocol, this is by Jaslok Hospital and Research Center. They published their single center comparative analysis of ABO compatible versus ABO incompatible kidney transplant with the short-term 1-year follow-up. So this was single center prospective observational study, a duration of 2 years, which was done at Jaslok Hospital with rituximab as a part of desensitization, and plasmapheresis was given to reduce antibody titers to target isogluten titer of less than 1:8, and induction agent was either ATG or basiliximab or ATLG, and the triple maintenance immunosuppression. And the immunosuppression was started 7 days prior to transplant. And the outcomes evaluated 1 year were rejection episodes as well as graft dysfunction. So they had a total of 95 patients, of which 29 patients were ABO incompatible, with most common ABO incompatible combination was B2O. And the clinical outcome was that there was no significant difference between ABO incompatible versus ABO compatible with respect to rejection episodes, the graft dysfunction, graft loss, or mortality. However, the infection rate was slightly higher in the ABO incompatible group, the most frequent infection being urinary tract infections. And again, CMV infection was a second most common frequent viral infection. And severe infections, however, which required hospitalization ICU, were not significantly different between the two groups. So they found that ABO incompatible kidney transplant showed non-inferior short-term outcomes when compared to ABO compatible transplant, though with a slightly heightened risk of infections. So going on to the last poll.
So this is a It's one of the problems, one of the things which we don't like to talk about in ABO incompatible transplant, but which happens once in a while, and even our lifespan comes down because of this. So how commonly do you see ABMR and ABO incompatible transplant? So it can be very rarely, around 10 to 20%, 50%, or 5 to 10%. So you can attempt this poll. Okay, can stop the poll. So 10 to 20%. So I can see that. So that is one of the problems with ABO incompatible, because when you do ABO compatible transplant, you're not talking about ABMR. It's not a very common thing, and usually it's treatable. But the ABMR ABO is quite terrible. I think we'll talk a little bit of it later. So we'll finish the presentation and then we can have a discussion on that. So we'll continue with this, because we want to discuss some more about this later on.
Going ahead, shall I go ahead?
Yeah, go ahead, go ahead.
So going ahead with one of the important data on ABO incompatible transplant. This is the largest data of ABO incompatible transplant in the world. It is a multi-center retrospective cohort study which looked into the management protocols and clinical outcomes after ABO incompatible kidney transplantation in India. And there were a lot of centers, of which the center Dish Balin sir also is a part of the study, and then Bin Hafiq sir and Dr. Firoz also, and Abhi
I think your center is also part of it, no? AB Abraham is also there.
Our center was also part of this study.
Yeah.
So this is a retrospective analysis where they looked into the management protocols as the clinical outcomes, and with the transplantation which was done between 2011 and 2022 across 25 centers. There were a total of 1,759 transplantation, and the protocol was rituximab with varying doses, majority using a 200 milligram dose, around 50%, and 12% had no induction. And IVIG was used around 37% of patients, and immunosuppression was used to less than 10%, around 8.2%. And what they found, the outcome was that the mortality was around 9, at the end of 36 months or 3 years, the mortality was around 9.49%, and with a graft loss of around 7.73%. And a biopsy pollen acute rejection, which was around 12.6%. So these were comparable and not significantly higher than the compatible transplant. However, the infection risk was slightly higher to the tune of around 17.4%. And the study concluded that this is the largest multi-center study which looked into various protocols and management strategies, and with a acceptable outcome when compared to ABO compatible transplant. So now let us look into the maintenance immunosuppression in these patients. It is usually the triple immunosuppression consisting of tacrolimus, mycophenolate mofetil, and steroids. And once daily tacrolimus has also been studied in ABO incompatible cases. So this is usually preferred for its ease of convenience, the single dosing, and a more steady tacrolimus levels, as well as adherence to the regimen. So this once daily versus twice daily tacrolimus in patients in ABO in transplantation, live donor transplantation, including ABO as well as HLA compatible and incompatible, as a randomized trial was done. So they looked into patients who received twice daily tacrolimus as well as once daily tacrolimus and once daily tablet, and the objective was to evaluate whether once daily tacrolimus was non-inferior to the BD dosage with a 5-year period, looking into the outcomes. And there are around 62 patients in the once daily group and around 63 patients in the BD group. And the primary endpoint was graft failure. So the two arms were almost comparable with regard to the creatinine as well as the other parameters. So finally, they found that the cumulative graft failure at 5 years in the once daily was around 6.5% when compared to 9.5% in the BD dosage. And this was, however, not statistically significant, and eGFR was not significantly different in the both arms. And the 5-year biopsy-proven acute rejection was around 30% in the once daily and 32% TAC BD, which was also not significantly different. So once daily tacrolimus is can be used in ABO incompatible transplant with non-inferior outcomes. Now let us look into the real world ABO incompatible transplant cases and what is the protocol, summing up what is the protocol which is to be used and how to go ahead with ABO incompatible transplant. So recipient evaluation, you have to have a routine immunological pre-transplant workup, which includes the flow cytometric analysis, CDC cross-match, as well as HLA antibody screening with a single antigen meet preferably. And then the antibody titers are checked with the help of either a column method or a tube method. And then the legal clearance, cardiovascular and pulmonary fitness is required, and adequate desensitization hemodialysis prior to the transplant. Regarding the age, there is an absolute age cutoff, but the immunological as well as infection risk of these patients to be taken into account. And then after checking the titers before the transplant, you have to decide on the plasmapheresis. The titers usually accepted are usually generally the titers are less than 1:256, but up to titer of 1:2024 can be considered depending upon the clinical circumstances. And they can use of immunosuppression column is usually considered when the titers do not reduce by 1 log after 2 plasmapheresis, or you have a very high titers which are not coming down with the regular plasma exchange. And the titers usually checked on at least 3 occasions. Usually the titers are checked following each plasmapheresis sessions, and then the number of plasma exchanges are decided accordingly. And post-transplant, usually the titers are monitored for a week or so, and then though it is, I mean, some centers may not recommend, but then we usually do it, the titers after the transplant daily for 3 to 4 days. And then the coexisting HLA incompatibility will also change the risk profile, and that should be considered on an individual case-by-case basis. And regarding the cutoff titers, usually the aim is around less than 1:8 in most centers, but the Indian Working Group recommendations around 1:16, and the rituximab is usually given as a standard dose of usually the low dose is currently preferred 200 milligram, and if the titers are quite high, you may even consider 500 milligram. So we then in the titers are in some usually checked closely for the post-transplant for a few days. And regarding the induction, the immunosuppression protocol, rituximab is usually given as a low dose 200 milligram. And this is usually given at least 2 weeks prior to the date of transplant, and 1 week before the anticipated date plan of plasmapheresis. There's pre-medications also given with rituximab. And then the immunosuppressants, the plasma exchange usually started at least 5 to 10 days prior to the transplant, depending upon the number of exchanges which is required. Usually, each plasma exchange will reduce 1 log titer, and depending on number of the exchange, the number of the high titers, the number of exchanges are determined. And the immunosuppressants are usually started at least 1 week prior to the transplant. And the post-exchange, usually the plasma exchange, the replacement is with albumin initially, and then towards the last few exchanges, with the fresh frozen plasma is also added, preferably the donor or AB blood group plasma is given to reduce the bleeding risk. And post exchange, usually coagulation screen is also done because there is heightened risk of bleeding. And also under even sometimes TEG is used to see if they look at the bleeding profile. And the tacrolimus post exchange, some centers even use fibrinogen levels, and if it's less than 200, coagulation screen must be repeated on the day of surgery. And the standard injection therapy, usually basiliximab is used. So for post the transplant, usually the steroids are started, and steroids are usually the day one. Usually methylprednisolone IV is given. Varying doses of 500 to 250 milligram, and then tapering down to 125, 250 and 125 day 2 and day 3, followed by oral prednisolone 30 mg, which is tapered over the next 1 to 3 months. And regarding the tacrolimus levels, month 1, the target level is kept around 7 to 10, and 2 to 3, 6 to 9, and more than month 3, it is kept around 4 to 8. And cotrimoxazole and valgain secrol also added up to 6 months as a infection prophylaxis. So that is the usual protocol which is followed in ABO incompatible transplant. So finally, summing up, the key takeaways are the ABO incompatible kidney transplant offers comparative outcomes, and the ABO, it is comparable to ABO compatible transplantation. And rituximab has now replaced splenectomy. Splenectomy was early used, and the low dose rituximab is currently being used. And there is a shift towards individualized protocol. Earlier, it was a one size fits all, but based on the patient specific immune profiles and basal antibody titers, and the dose of immunosuppression as well as the plasmapheresis exchanges is modified. And the minimal post-transplant plexus being used nowadays. Only plasma exchange is primarily used pre-transplant. And there is a judicious use of immunosuppression along with immunoabsorption columns because of the cost factor. Only if they are used if the antibody titers do not come down by 50% after 2 consecutive sections of plasmapheresis. So ABO incompatible is offering comparable outcomes with less invasive immunosuppressing strategies.
Yeah, thank you.